think, there's been a lot of controversy. If you step back 10, 15 years, we were much more in the camp of higher calories, get there fast, let's not monitor so much. And now we know the importance of how energy delivery during that, especially during that really acute inflammatory phase, how that potentially may have harm on our patients. And I think this highlights the need and maybe some of the areas where we have some education to do of at what point do we tip that scale and say, okay, now it's safe. Now we may reduce our risk of harm of delivering higher calories or higher protein. I think you mentioned targeted markers for whether that be serum markers or functional markers. Can you explain a little bit more about what you have in mind here and if there is any research currently being conducted? You mentioned Nexus and EffortX, but a little bit more I think would be helpful to apply to practice.
Yeah, absolutely. I really laud the European Society of Parenteral and Enteral Nutrition. They were the first to really partition critical illness. So they're the ones who said, look, there's this acute phase, and this acute phase is an early acute phase. That's when patients come in, hot, right? They're highly inflamed. Perhaps they're on vasopressors. They're febrile. They have high ventilatory, requirements, and then that starts to wane. And maybe that forms the early acute phase. Maybe, I'm not sure. But then perhaps when the vasopressor comes off, they start to defervesce, convalesce, then we're heading into more of a chronic phase. I don't think we know exactly when patients transition between these phases. My clinical judgment would tell me that, okay, maybe the vasopressor is coming down, maybe we're starting to get better. The fever curve is getting better. Okay, maybe we're starting to move in a better direction as well. And we don't have any good biomarkers to inform us of that. Now, Gordon Doig did a trial many years ago where he used a phosphate level to determine how aggressively we ramp up or ramp down our nutrition support. And these were patients who had a high risk of refeeding. So those patients who had hypophosphatemia. And so if the phosphate level was low, you keep the nutrition prescription low in the intervention arm. Versus the standard group arm just kind of ramped up their prescription. That's an example of how we can use a marker to inform how quickly we can ramp up our nutrition. And it turns out that in his trial, that was met with an improvement in mortality. In other words, the group that was guided by a phosphate level to tell them how quickly they should ramp their nutrition dose had an improvement in mortality compared to the group that was guided by some arbitrary number in going up on the nutrition dose. And I think that's what's lacking, and I think that's the next frontier. And an example of that could be this omics, paradigm that we're in. And metabolomics is one such way to identify fingerprints of those individuals who stand to benefit from our nutrition intervention. I think it's really naive to think that one nutrition prescription is going to fit every single critically ill patient, because the patients come in with different comorbidities, they acquire different comorbidities, their trajectories are certainly different, and then the interventions they receive as a result of that is different. And so I think we have a lot of work to do in identifying which patients are going to truly benefit from our nutrition interventions, including protein. And I think the next phase is to identify these biomarkers that help guide those interventions.
Sure. And I mean, absolutely, there's differences in clinical care outcomes, and it's possible that patients who were maybe requiring PN earlier in their stay potentially were sicker, but we don't know because we don't have that data, of course. Mm-hmm. I think another piece that sticks out to me here too is, with calorie exposure, if we go back 10 years, we start to see this difference in higher calorie earlier in earlier delivery in the critical illness phase. What are your thoughts on a more slow advancement of that protein versus targeting higher protein at the beginning? Might we see that this is the way we're moving in terms of clinical practice with protein as well?
Yeah, I think that's where there's a paradigm shift happening, and so when we realized, and this was before my time, of course, when there was a realization that patients are malnourished who enter the ICU, but then certainly are put through the interventions and the disease process of being critically ill. And so at the time, the thought was, hey, give them a lot of calories and try and, reverse, the malnutrition. And I think what we've seen is that giving patients a lot of energy, but that energy also in the form of protein, is met with, harm. And, Steve McClave calls it, unwanted baggage. And that unwanted baggage comes in many forms. And so one way it comes is enteral feeding intolerance, and especially if you look at the sickest of the sickest patients, particularly those who are on high doses of, vasopressors, it's met with things like bowel ischemia and bowel necrosis, right? Other forms of unwanted baggage include, if we push, too much, too fast in the early acute phase, is hyperglycemia. And hyperglycemia has, of course, been a marker of bad outcomes in critically ill patients. Another form of unwanted baggage in terms of pushing things too early is mitochondrial dysfunction. When there's a ton of oxidative stress and the battery, right, the mitochondria isn't working very well, well, suddenly it has to now process all this nutrition that is being delivered. And if it can't, it tends to create more oxidative stress. And the same can go for this concept of autophagy. I'm not sure, anyone truly understands the concept of autophagy, but my, limited understanding of it is that, again, when the cells are damaged, there's a housekeeping mechanism that comes in to try and, get rid of all that damage. And when we feed people, that housekeeping mechanism called autophagy is turned off, and that can lead to more oxidative stress. And we now have, again, many randomized controlled trials, again, Eden, Permit, Target, Nutria 3, that's all seem to suggest that, less may be more, at least during the early acute phase of critical illness. And there's ongoing trials, particularly related to protein, that are looking at a higher amount of protein in those later stages of critical illness, albeit acute late stage, if not, chronic stage. But again, those trials are using days as arbitrary sort of transition points between the early stage and that late stage of critical illness.
Yeah, and I think it's really interesting and maybe not unexpected, as we know those sicker patients with the energy exposure, especially early in that phase, we may see harm there, which is why we have these drastic differences in our energy targets from our guidelines. But I think that the piece to me in our conversations that have stuck out is the difference in renal replacement therapy versus non-renal replacement therapy. I think we have to be careful to not over extrapolate here too, because there may be differences, and you've spoken a little bit in prior presentations about kind of how those might differ. So can you elaborate a bit more on why you focus on non-CRT AKI patients here?
Yeah, we know that in patients who are on renal replacement therapy, they can lose like 9 to 10 grams of amino acids, with dialysis. And those patients are often, in a negative nitrogen balance. And so perhaps giving those patients more protein can at least push them to a neutral, if not positive, nitrogen balance. And we actually have randomized controlled trial data that suggests that, where individuals have pushed up to 2.5 grams per kilogram per day of protein in patients with acute kidney injury on renal replacement therapy. And they have achieved a positive nitrogen balance. And some secondary outcomes even showed a signal for benefit with greater amounts of protein in that population. We have not, completed the analyses quite yet. But again, the one thing that we do seem to know is that pushing protein in acute kidney injury where there's no capacity to excrete it just means that there's capacity for increased oxidation and oxidative damage and increased work, for the mitochondria for those individuals. That's hypothesis generating, at least, and seem to suggest that there's more harm in those patients with acute kidney injury who are not receiving dialysis and don't have the capacity to, lose amino acids, if you will.
I think it's very different than how I was trained, actually, and in terms of how much protein delivered to these patients who maybe were not previously having any sort of kidney injury or kidney failure prior to admission or prior to ICU admission. And it goes against what many of us have been classically trained to do. So I think distinguishing between renal replacement therapy and not, we need to learn more here and better understand how to apply this to our practice. You mentioned the lack of ability to excrete these nitrogenous wastes and these byproducts of that protein breakdown. Do you have any suggestions on whether a clinician should know at what point these, like, let's say the BUN creatinine ratio, is there a point where we might see harm here for over delivering or under delivering protein?
Yeah, good question. Zudin Putticherry out of England has used what's called the urine to creatinine ratio, and the higher the urea to creatinine ratio, and the higher the urea to creatinine ratio implies that there's a greater amount of urea, and urea of course is the breakdown product of some of these amino acids. And using that, the higher the value, perhaps we could say to ourselves, maybe we shouldn't push so much protein in this individual whose urea to creatinine ratio is going up on a day-by-day basis. Now, again, it could serve as a potential biomarker to dose patients. But until we have some of that, formal data, I think lowering the protein prescription in acute kidney injury patients who are not receiving renal replacement therapy may be a reasonable step.
Sure. So, then thinking with that in mind, how do we apply either the ASPEN or the ASPEN guidelines, which do differ? Should we aim that 1.3 as per ASPEN rather, or 1.2 to 2 per ASPEN? And what are your suggestions here in terms of clinician recommendations for practice?
The 2016 and really the 2022 guideline recommendations for protein were really no different. And it encompassed all patients. And of course, the 2016 had identified some, subgroups, of patients, like those who were obese, for example. But I think moving forward, one thing we need to do is identify the subgroups where there were harm, and I look at those patients in a separate recommendation. Again, it's those with acute kidney injury not receiving renal replacement therapy, and then it's those, sicker patients where we're pushing more energy and protein during the early acute phase of critical illness, and taking a step back and saying, hey, maybe we shouldn't push so much during that early acute phase, because here's the signals of harm from these trials that seem to suggest that.
Sure. How do you suggest, this is always a question that comes up when we talk about protein and dosing and the guidelines, what weight do clinicians use when actually choosing, per kilo? Are we using actual weight? Are we using ideal body weight? Are we using pre-admission dry weight? And how does that differ when we have our obese patients? You guys, for the study, looked at BMIs less than 25 and greater than 35, but what happens in between? And what weight do clinicians choose when making these protein goals?
Yeah, that's a really good question. The short answer is I don't know. And I would say that, what we're doing is probably if you're not obese, actual body weight. And then if you are obese, then your predicted body weight. But yeah, the short answer is I'm not sure.
Yeah, I know it's really
that's a conundrum.
It is, and I think when I go to Aspen, I remember last year hearing clinicians when the guidelines were being discussed, and this particular question came up. This is something we all want to know more about. But it does apply a lot. As we know, the obese population in ICUs has grown over the last several years, and especially when we look at these long-term patients who may come and go from the ICU several times, it really does make it challenging for clinicians. So I think the idea of early in critical illness, especially for those who have some of these signals for harm, so the AKIs without CRTs, maybe our higher SOFA scores, especially in our malnourished patients, it makes sense to slowly ramp up the calories and specifically the protein, but maybe over time apply higher protein goals as we hit more of those longer acute phase critical illnesses or chronic critical illness. And then again, what happens when they leave the ICU? I know critical care is your area of expertise, but do you have any suggestions of at what point clinicians should be reevaluating these goals?
Yeah, that's a good question. I don't know if we have any data to inform us, what the goals are once these patients, leave the ICU. I think that's an area that's ripe for research. But what I will say is that if they're leaving the ICU, then that early and late and even that chronic phase of critical illness may start to be really behind them. And so now we're talking about getting them up and moving. Now we're, talking about capacity to do more, physical therapy, resistance exercise training. And so if there's a means to, monitor anabolic response in those patients that you are, exercising, then perhaps, a greater amount of protein in that patient population would translate into a greater, anabolic response. But right now, I don't know if we have a good way of measuring that anabolic response in those patients. And a lot of it may just be based on the recommended daily allowance, right? Which is what happens after these patients leave the ICU.
Yeah, so many unanswered questions. There's a lot of room for us to learn more about critical illness and even the post-critical illness phases in terms of how to improve functional outcomes for these survivors of critical illness. So, well, thank you, Dr. Patel. Your information and your insight is always valuable. We appreciate your willingness to speak with us today.
Be sure to watch for upcoming Channel One videos on nutrition and learn more from our esteemed colleagues. Have a great day.